So let's just jump into this, and we know that the disclaimer information, and here's my financial disclosures, including Avedro, but a lot of times we don't think about this from the patient's perspective, and it's really scary to have keratoconus. It's a progressive disease almost always, and one that can lead to cornea transplant, and cornea transplant is far from benign. And so how the patient goes through this is that they almost always get kind of diagnosed by their optometrist. If their optometrist has a penicam or topography, they can get diagnosed there. But hey, I think that there's something going on here. Maybe you have keratoconus. Gets referred into a ophthalmologist typically, where we confirm the diagnosis of keratoconus, and almost always that's progressive keratoconus, especially if they're young. I mean, it's almost every time. And so then we go through the patient conversation. We talk about their diagnosis, their treatment plan, and their insurance coverage. And I'll just give you my conversation that I have with them real quickly. My conversation goes like this. You have keratoconus. Keratoconus is a disease that's probably partially genetic and partially environmental. So you've got a naturally weak cornea. And that gets worse if you're rubbing your eyes. So it's really, really important that you stop rubbing your eyes. And probably no matter what we do, if you keep rubbing your eyes, you're gonna win the tug of war. But the good news is that we can probably make it so that you live an entirely normal life, especially if we catch their keratoconus early. And so what we need to do is we need to cross-link you. What cross-linking is we use an ultraviolet light in combination with a drug, and we shine that light, and that creates these little cross-links in the cornea. It's kind of like if you took a ream of paper and let it sag, it could sag. But if you put a couple of rivets in that, it becomes like a book, and it's stiff, and it doesn't bend anymore. And I kind of show them my hand that a normal cornea is like this, and a keratoconic cornea starts to look like that. And they get that very quickly. And I say, it used to be that we'd ask you to stop rubbing your eyes, use contact lenses, and you'd have a decent chance of going on to needing a cornea transplant someday. But now with cross-linking, we can stop keratoconus in its tracks almost all of the time, as long as we catch you early enough. Now, this technology is new to the United States. It's not new, it's new to the United States. And it's kind of in this awkward adolescent period because, as we know, insurance companies aren't that interested in paying for new technologies. And so we need to get you cross-linked. We'll figure out a way to get you cross-linked. Insurance may or may not cover it. We're gonna fight hard for it, and we need you to fight hard for it, not only for yourself, but for other folks. And that's kind of my conversation that I have with the patient, and then I pass it off to the team. So the team is scheduled, and the team looks at their coverage, and there's really one of three situations. One, they've got a positive coverage policy. That means their insurance says, yes, we pay for it. We recognize that this is necessary, and that's increasing. I was just talking with my biller today, and she said probably 70% of the time insurance is covering keratoconus at fair rates, or cross-linking at fair rates right now in our region. I asked her what it was a year ago. She said probably 30%. So we're really moving the needle on that, but there's still a lot of times that it's not covered by insurance. Two, do they have a negative coverage policy? Meaning, we've looked at the data and we say no. And number three, does the insurance carrier just not say anything? So if it's a positive coverage policy, and you'll see that these slides are pretty similar, basically enlist ARCH. ARCH is a program put on by Avedro to help take the gobbledygook out of your hands and help you categorize your patient and make it so they get access to cross-linking in the most economical way possible. One thing that's important is to make sure that what is progressive keratoconus is within their guidelines. Some insurers have very little for guidelines, others have very specific guidelines, usually around the FDA trial that was done for cross-linking. And so you want to have your team pay attention to that and make sure they know what they're looking for. And NAHB is much like an ABN for Medicare patients, and basically that's saying that if you get low coverage back or it's not covered, you as a patient are responsible, and I think that that's important to help protect the practice. But in our practice, we're not going to let finances stop a patient from getting cross-linked. And I will say that Avedro has done a fantastic job of sharing that burden with us, and they'll provide, free medication or reduced rate medication through the ARCH program and other programs to make sure patients get what they need. This last one is kind of important too, and that is if there is low reimbursement, then we may have to go back and fight with the insurance company a little bit more. A negative coverage policy, again, Arch can help. And here's what I do here. If they say no, I feel like everybody that has keratoconus, progressive keratoconus, should get cross-linked. So I'm gonna fight for that, and it's not that much fun, but it's what our duty is to make sure that our patients can get coverage, and I ask them to fight for it too. And here's my strategy. I've got a list of 20 peer-reviewed articles that I send to the medical director, and I say, hey, I want you to review this data. Insurance coverage is happening more and more, and I don't understand why you don't care about your members when all these other insurance companies do, and I'd like you to read these articles. And then they don't read them. And they come back and they say, well, it says that it's experimental or something, and they don't read them. And I say, so wait a second, I want to make sure that I understand this. I'm looking this patient in the eye. I know that this is the right treatment. You're responsible for them. They paid you dues, and you're not even going to read the peer-reviewed literature, and you're going to say no. And then I just let that sit. And then finally they say, okay, I'll read the literature. They don't, and they come back 2 weeks later and they approve the treatment. And so it's kind of a reversal, which is kind of fun, to put all the paperwork back on the insurance companies and make them do the work, and it feels like we're fighting for our patients, and we have the patients do the same thing. And a silent policy is more educational. It's a little less adversarial, and we say, here's why you should cover keratoconus. And this is easy because it really is in the payer's best interest to not do a cornea transplant if they don't have to. And so it goes through the kind of same things. And then I'll also say that you should put the predetermination letter after you have a conversation and the drug invoice in with the claims that you submit, so they see what you're paying and what the costs are, so that you're more likely to get fair reimbursement. And so the common thread is that predetermination, knowing what the insurers are going to do, is helpful for patients and helpful for you. Set the expectations with them that the offices we're gonna help you. We have a common enemy. It's the insurance company in this scenario when they're not paying for it, and we're gonna work hard, but we want you to work hard and rattle that cage to have an ABN or an NAHB in place. And the ARCH program really is helpful to help solve this for patients. And so, it's worked really well, and that's why we've seen such tremendous progress, and soon this kind of awkward period will be behind us and we'll have good reimbursement. And the last thing that I'll say is, cross-linking is expensive when you look at it as a one-time treatment, but when you look at it as a lifetime treatment that you do once, we're preventing a lifetime of all the drugs that go along with a cornea transplant, the rejections, the repeat transplants, potentially the very expensive scleral lenses and other things that go along with it. And so there are very few values there's very few things in ophthalmology that have the same level of value as the one-time treatment that keratoconus or the cross-linking does to prevent future cornea transplants. Thanks. Thank you.
Thanks, John, and thank you all for applauding more for him. So joining us on the panel, George Waring from Charleston, South Carolina, Dick Lindstrom from Minneapolis, and Ron Krueger from Cleveland. So let's chat about that a little bit, John, and please, again, if there are any questions or comments, please pass them on through the cards. Any thoughts? George, is there anything different that you've been doing in your practice from what John described?
First off, I thought that was an elegant summary of a very, very, very complex subject. I can't remember the last time I heard that summarized so well. So thank you for a wonderful job. And I actually learned a good bit through that talk myself. We did a couple additional pearls. I believe we are all going through the learning process on this, and this really is a long-term commitment to do what's best for our patients. And it's an interesting exercise to have the opportunity to do it. So we'll try to set the expectations in advance with our patients. We'll kind of pre-screen them to determine what category that John so eloquently laid out that they may fall in with their insurance. And then we'll also let them know that we're going to be working with somebody on their behalf which is the ARCH program, which is a fabulous, fabulous program and so important in navigating this process to make sure that this is, that what scenario does it look like. We'll try to obtain the predetermination letter, and we try to minimize their visits as we navigate the process. So we try not to have them come back just to say, well, you know what, we actually don't know what your insurance company is going to do yet. But the flip side of that is we don't want to lose them, and we want to make sure that we can deliver on the treatment however it pans out. And so it's really kind of case by case, as you can imagine. But the key is just to set the expectation in advance, let them know that you're doing your very best, which is in earnest, to get them the treatment that they deserve, and just communicate openly and really work with ARCH to help you do it.
So I would think, at least if I'm speaking for myself in my practice, but probably in your practices too, none of us are patient enough to have the time to go over all of this with patients. And I think, John, you did a nice job of describing what you do. But then how do you, maybe Ron or Dick, if you can comment on, how do you hand this off to your staff? How do they manage this process, and how do they educate the patients and then work with the insurance companies? So some of the logistics before we get into some of the clinical information next.
Yeah, I could say just real quick that we're all pretty busy in our practices, and it's really hard to sit down and talk about insurance aspects of a procedure like cross-linking. And so we do have a dedicated staff person whose whole job is to talk with the patient and begin to initiate conversations with the insurance about getting coverage. And the one thing we'll say is you'll be able to talk to Christine a little bit more about this in terms of how we can get this process, but the insurance is going to have to approve it. And then they go ahead and talk with Christine. And that just frees up the time for us to move on to the next patient and keep the practice moving.
Okay. Yeah, I think what I've seen certainly in my own practice is that we've developed a similar process where we have staff well educated, and from the Avedro perspective, we have a team of reimbursement specialists that can help our staff members get educated as well, and then help facilitate those discussions with the insurance carriers. Dick, is there anything else? I mean, you're in a large group that does a lot of cornea work. Is there anything else you can suggest as hints for all of us?
Well, in the end, the surgeons, and we have 6 of them in our group that are doing these treatments, have to decide the policy. But I agree that we need to delegate it, and I think the surgeon needs to tell the patient that we're in a transition period, exactly like John said, where we may or may not get reimbursement. Couple realities. Number one, our fee is higher than we would set it in the normal world, in quotes, because that's the way the insurance world works. And so we have to set a relatively high fee on paper, although we rarely get reimbursed that. But if we set a really low fee, we don't get reimbursed, a small percentage of the low fee. So you have to sit down and with reimbursement advisors and with the help of Avedro decide where to set that fee, because that will be important to us long term. And then for the patient who can't get reimbursement, we have a cash pay discount, and we have the same type of cash pay discount available really for any procedure. Actually, most of you are doing the same thing in cataract surgery or the like. You have a relatively high fee, you don't get paid that, and then if someone comes along and is willing to pay cash, then you have a cash pay discount. That's totally legal and appropriate, and so that you can do that. And then the final thing I think that you need to decide is that if there's no reimbursement, there's no ability for the patient to pay a meaningful fee, are you going to treat them or let them progress and go blind? And in our group, we have decided when we fight the battle and the patient fights the battle with us, and that we lose the battle and they actually are indigent and don't have any ability to pay for their treatment, we treat them, and we do that whether you have a cataract or need a corneal transplant or need collagen cross-linking. But again, the person you delegate to can't make that decision for you, so you have to sort of tell them to work through the system. But let's say you fought the battle for 4 to 6 months and there's no reimbursement, they can't afford it, then at some level you may need to decide to treat at whatever the patient can afford. In South Dakota, it's a few roosters and a couple of hens, but we basically feel obligated to take care of our neighbors. So in the end, at the current stage of things, sometimes you end up having to do some very low reimbursement or no reimbursement treatments. And I think if you get into this field, you have to accept that. And there are some doctors that aren't willing to accept that, and so they're actually not, in this field.
And I would underline that. I would say that I tell patients and our staff, we believe in this technology so much, we're going to find a way to get them treated. I will also say that as reimbursement, that gets less and less, and it is a modest financial win for our practice to offer cross-linking.
So I think maybe I'll just give a little bit of a commentary on some of these suggestions, because I think they're all impactful for what we can all do in our practices. I think what we've heard at Avedro is that the uptake of insurance plans covering cross-linking as a new procedure, a new technology, new drug, has been more rapid than most other procedures. And even though it's been painful for all of us, it is something that's made tremendous progress. Almost all of the national carriers are now covering it. Over 140 million lives, which is most of the commercial patient base, is now covered. And the challenge is that we don't know exactly how much they're going to cover, because it's a temporary code and that takes time to process and often takes appeals and the things that John was describing earlier. But I think what we're hearing from all of our colleagues is that practices are helping each other, because companies can only do so much. They can't help guide pricing or other things, of course. But doctors and practice administrators are helping each other with the process, and Avedro, as I mentioned earlier, has reimbursement specialists that can help with some of that. But I think we're seeing that hopefully we're over the hump to some degree. And going back to the patient part of it, both John and Dick mentioned that for patients that are not able to afford the procedure, ultimately, there is a patient assistance program that Avedro has provided that allows patients to get the drug without a cost. So I think everyone's working together to try to figure out how best to serve these patients with keratoconus that have a real need. As John mentioned, this is something that hopefully we all know ultimately reduces other need for care, corneal transplants, et cetera.